Hello everyone, thank you again for inviting me to speak something that's more clinical this time than I usually speak about regulation, and also this time is more related to what I really do by day, and it's my daily practice in my department. So we can talk something more clinical for this time. No disclosures. So here, learning objectives, we have the challenge of respiratory artifacts in radiotherapy. We'll talk about capacity for radiotherapy planning, the management of respiratory excursion, capacity with respiratory gating, and which will be the role of nuclear medicine technologists in this business. So what we can talk about radiation therapy. So technological evaluation in radiation therapy allows really great personalization of treatment and those confirmation of the target organ. The guys for radiotherapy are really trying to tailor the therapy for every patient. So we need great precision in irradiating the target organ with the requested dose. And what we also want is ill tissue dose reduction. So a multidisciplinary approach is needed, and molecular imaging may play a major role in this business. One challenge, respiratory movements in radiation therapy. When we have thoracic and abdominal lesions, such as tumors in the lungs, liver, or the liver, are influenced by respiratory movements. The range of movement effects may vary even within the same organ, so we can have a lesion in the apex, it will have a different movement than a lesion in the base of the lungs. And respiratory excursion may produce movement artifacts ranging from a few millimeters to even 2-3 centimeters during normal respirations. The speed or moment of the lesion may vary according to the respiratory frequencies and the relationship with the patient's general condition. So if we have a patient with bad general condition, may have a more movement because he is breathing more deeper. And also change in this is really a challenge for radiotherapy delivery. Tumors may be brought completely outside the treated volume. Dose guidance may be inaccurate. Tumor will receive lower dose than expected with major side dose on healthy tissue. And this effect often suggests radiotherapies to enlarge the margin of treated volume. And so we have the irradiation of a larger volume of healthy tissues. What does it mean? It means that we are putting really huge field to be sure to irradiate the tumors. But we also give a lot of dose to the healthy tissues around the tumors that we are going to treat. So here some little bit talk about the RT planning process. We have a gross tumor volume that is and also biological target volume. We'll talk also about the clinical target volume that's considered also micro disease around the tumor. We have the internal target volume is about how the tumor move. And also we have the setup margin that must consider also a little bit parts of what is the machine adapting to that. As you can see, we are radiating really a larger wall than what is a real lesion. So how it happens, PET-CT? PET-CT really improvement treatment planning, helping in define the metabolic active tumor volume and minimizing the risk of geographical miss. So PET helps defining the biological target volume that integrated with the clinical gross tumor volume characterize the tumor tissues to be treated. PET information may enable a significant reduction of radiation target fields, sparing healthy tissue, and reducing the side effects of the treatment. What does it mean? We know where the active tumor part is, and we really try to treat only the active part that is responsible to the radiation therapy. So, image acquisition for RT planning and treatment needs. The consistencies of tabletops and the use of laser lights for patient setups. We have to be in the same situation as it can be the treatment. A definition of patient initial position. So we know how the patient will be doing radiotherapy. We do PET-CT with the same position. And we have to use the same immobilization device of the radiotherapy department. So they bring our immobilization device, we use them in our with our PET scanner. Well, patient physical limitation and psychological facts need to be taken into account. A PET scanner is lasting from 20 to 30 minutes. It's a long while. And also we have to take account that it can be really stressful for the patient. And physical condition may really change people. They are really sometimes are really suffering from PET-CT for radiotherapy plan. We have to take into account this kind of problems. We need to record setup data. So people say, okay, we plan it this way. You know that and they have to record really accurately. And the ideal situation is having a radiation therapist involved in the patient in imaging capacity. We really need a close liaison between the two departments and clear detailed protocols for every type of patient setup for localization and for localization of tumor site. So we need really to know what's happening in radiation therapy department and to know to have a good PET-CT imaging. Let's back to what's problem in motion management techniques. So PET study performed in free conditions are affected by motion artifacts, as was shown in the talk yesterday, and resulting in image degradation effect. But when we have activity of constant source appears mirrored over the volume of this patient, because a loss of the lesion detectability. There is an underestimation of SUV, overestimation of the volume, and in integrated capacity tomographs, mention a special misalignment in data registration. So sometimes we have a CT showing the lesion in place and the PET showing that in another place. It happens when they have really large exclusion. Here an example. Here we got the mouse. Yes, you can see how much is the spatial difference between the lesions. So we have a lesion that probably is less than 6.9 millimeters. It happens to be 12 millimeters. It's really a large exclusion on that. You can see how it changed the lesions. What we can do? There are some excursions of some type of management. This is the breakhold CT. So where the procedure is was used mainly for CT and we used to have breakhold. Well, intraoperative planning is helpful only if the treatment is short enough to allow breakholds. Otherwise, it's unuseful and needs really great help from the patients. So in PET-CT is limited only a single field of view cannot be taken for all the exam. And also we need a lot of respiratory coaching to ensure that the patient will hold their breath. Images are most free of motion artifacts and minimize co-registration mismatch. And the SUV lesion, SUV and the detectable lesion is more accurate. It's useful, well, only if there is a breakhold condition for therapy. And it depends heavily on patient cooperation and physical ability to comply breakhold. Well, breakhold PET-CT, as you can see, there is a case that was made in Sweden. As you can see the difference between having a breakhold CT. The misregistration is now really huge. Now we have quite a better example. Okay, we are not against breakhold, but it's only for some particular cases. Actually, we don't want to use it in the department. I wanted to show you why, because it can be used in some situations. Well, respiratory gating for the PET-CT. The aim is producing a motion-free and well-mastered pattern CT image corresponding to a specific phase of the patient respiratory cycle. The clinical input could be in a detection and accurate metabolic reduction of lesion affected by respiratory environment. And for radiation therapy is useful to assess the true volume of the tumor, and its real motion obtain an accurate target delineation, a personalized definition of the treatment plan. So this can be used both for diagnostic procedure and both for radiation therapy planning. What we need: a tomograph with a large FOV. Have a flat table, a radiation therapy setup, an emulation system as used in the department, the PET-CT gating alert, a patient respiratory monitoring system, and also a DICOM archive protocol. We'll talk about a couple of there are many systems that were used for respiratory gating. One was the spirometry system. It measures the respiratory flow of air incoming and outcoming from the lungs. Temperature sensor, it measures the temperature of the air incoming and outcoming from the nose during breathing. Well, we used it. We didn't use that, but just to show you. This one we used, it was a pressure sensor, and it's an elastic belt containing a load cell that can be fastened on patient abdomen. Every respiratory movement, the belt tightens, producing a change of the pressure inside the belt, which is measured with the load cells. So we have this with load cells to measure out the cursors. We started that PCC scan in this mode, but we use it on a previously selected patient. we use them only in patients with basal lung cancer. And the patient selected was suspected for that. And after the whole body PET, we didn't the only respiratory gating, we did a whole body PET CT, and then we do it on the one bed on the lungs, on the part of the lesion where we assumed that we should have a lesion. So what we did, well, there was the patient was instructed to keep the breathing regular, and then we tightened the load cell on the patient. Then we start recording the movement of the patients and trigger it with a retrospective model with 6 phases of respiratory. So the respiratory phases are divided in 6. And one acquisition data addressed to a selected respiratory phase that will undergo the gating post-processing. So only one phase will be really analyzed. Here we have a good case report because we had it with when there was a suspicion of basal lung cancer. We did a PET CT scan and the nodule was negative, but there was not enough activity. However, decided to perform a PET CT with respiratory gating, and there was a clear positivity to the FDG of the suspected node. And it was really good because we diagnosed a problem in a patient that would never receive a good diagnosis. Well, we have an experience that's comparable to literature data, and then the protocol performed PET CT with respiratory gating to all patients with suspected death. But we really had big problems in finding eligible patients because sometimes they come for a diagnosis, sometimes they come not of an accurate staging. So it was difficult to find patients for that. It's really time consuming, more than 20 minutes just for the bed. And at the time we had only one PET scanner available. So having the full schedule made it difficult to insert this method in the daily practice because we have to plan it the day before. It was really difficult to find eligible patients the day before. And the department also was, at the moment, they decided to switch from another type of respiratory gated method. So this time there was not any more compatibility. We had to use it only for diagnosis. So, well, it was a try, but actually we didn't proceed with that. But we didn't give up with respiratory gating. We said, we want to do it again. So we changed it also. And we changed it with having a new tomograph. We tried to adapt having a new system that the Opto electronic system. And it was the same that our radiation therapy department used. So we have a camera, an optical camera, with a simple box. And well, the camera should look at the movement of the box. And from this, it can trigger the acquisition of the PET and of the CT. Here I show how it works. You see the camera, the box of the patient, and that, and also you see how it was like before the respiration. This is was taken from Copenhagen, but it's the same. We use the same positioning. So I use the workflow, preparation and setup a immobilizing system as in the radiation therapy department. Patient training, injection, whole body CT for attenuation correction and co-registration, PET standard patient now we start to monitoring the patient, the breath of the patient. Then we do a CT 4D, it's about, here you can see the protocol that we use is just 1 minute. And then we do a LIS mode from 9 to 12 minutes acquisition with a single FOV. You can see how it works. This time we use all 8 cycles. We divide the cycle respiratory cycle in 8 parts, and we use all 8 parts. How you can see, really, this SUV max really change from one phase to another. And it's really interesting because you see how this, you really see when you do respiratory gating how movement affects your detectors in PET-CT. And you can see how it changed. So the same was really improved with that. Here another, you can see the difference between having a standard PET-CT and a respiratory gating PET-CT in co-registration. So where we work with, back to our images of the RT planning post, where we work with respiratory gating here. in defining these margins. They really can change. So, which is the role of technology in all of this? Well, patient preparation. You need really to talk with the patient and be able to have him cooperate with you. And patient training is needed. And a patient must be instructed about the study's purpose, because sometimes they get upset, why I have to do a long while, stay there for a long, you have to explain why are you doing that. And really training plays an important role in this, not only in gating, but also in every time you do opacity for radiotherapy planning. Well, the scanning time is longer. Audio and video cushion textures can be used. Sometimes they use it. We don't use that, but in some centers they use that. As well, you have to talk with the patient sometimes during the examination. And also this, we have to use the same approach both for the PET-CT imaging and for the radiation therapy treatment session. So as conclusion, well, really, respiratory gating seems to be a valuable tool in improving diagnostic performance of PET-CT and better defining the target volume for radiation therapy. Actually, we do not know if there is really an improvement in patient survival. That's really not, it's not still not known. And so we really feel that, well, with the continual stress to tailoring their treatments on patients, we really will feel that the routine clinical use of respiratory gating for the PET-CT will be appealing for the years to come. Well, we hope that in the future will be a routine, because it can really provide a specific internal volume definition, reducing overall planning target volume. But what we really want is to not treat with radiation therapy heat issues. That's what we really want, and to really lower side effects from radiation therapy. And also to be more effective and aggressive on really what we need to be treated by radiation therapy. Thank you for all.
Thank you. Any question for Mr. Castaneda? I have one question. What is the material of the box that you use in the second
Yes, plastic.
slide?
Plastic.
Plastic.
Yeah.
And how are you going to fix it on the skin?
This is a... Okay. This is a tricky issue because you got the point. One of the problems that we usually face, because we have that, we fix it with some adhesive and that. But the problem is when you have on that the mask from the radiation therapy, because the mask tends to not allow a lot of exclusion, so tends to be difficult to trigger, because we have a really low exclusion, and sometimes we lose some data for that. So it's really tricky. Sometimes we choose to have it really low, because we found that the abdomen moves quite the same, and triggering with the abdomen is better than triggering within the lungs. That's what we do radiation therapy, and it's quite tricky because. Well, usually just an adhesive is enough, but with radiation planning can be really challenging to fix the box.
Thank you for your talk. May I ask you how many CT slides you're using for your clinic, your lab?
For you say for respiratory gating, yes? We use, I think, 1.25 size millimeters, so it depends on the fork. It depends on the fork of the machine. It's 1.35 thick slice.
Okay. Are you saying that if I have a facility for doing respiratory gating and I'm not doing a radiotherapy planning, I shouldn't be bothered doing?
I'm not saying that. I'm not saying that. I'm saying that what is our main application is for radiation therapy planning, because we do radiation therapy planning on a daily basis. Daily basis is, I know that it's not so common to have it, but for me it's quite daily practice, because we are really asking for a lot of, we do about 2-3 patients a day. and with many tests about it. So it was completely natural to use it for that, because we feel that it's the much more impact. But also for diagnosis in some other centers, like in Milan, like San Raffaele Hospital, they use it and they have a lot of places, maybe I can give you some details on the chart. There are a lot of evidence of using it for diagnosis. Our experience with it was not so exciting with that, but other centers have better experience than us. So if you want, I can give you the details of some other people are using it for also for diagnosis.
I have one quick question. I'm just curious, technologist's role in, do you also need the external lasers? And if you do, does the technologist do that, or a combination of the radiotherapist and technologist? Does the radiotherapist come to the PET scanner and then position the patient? Just kind of curious of your general practice doing radiation therapy plan.
Well, actually, we have to think also, talking about competencies, that I am also a radiation therapy. So formally, even if I'm not able to, not even turn on a machine, but formally I'm able to also to do therapy planning without necessity, also with CT, also I do it with that. We started with a cooperation with them, so they came to our department, they show up, and they helped materially us to plan. After a while, they were so scared by radiation that they didn't come anymore, and they just left us to do it. This really a lot of problems to us, because sometimes we do not know what's really happening in their department. And this sometimes gives us to somehow we have to call them, discount, relative problems like that. And the focus to our suggestion is to really have cooperation, because we know that in a lot of countries there are different types, and we really have to cooperate, because with cooperation with the radiation therapy technology, you really know what's better for the patient. And so in the spirit of putting the patient, the focus on the patient, we really suggest you to, or at least to have a good schedule, to really know what's happening with the first planning, because we do not do it as the only planning. It's maybe just as a secondary planning. In some departments, they used to do everything on the city. In some department, like in Copenhagen, they are doing every plan. Okay, we plan the patients, they will do CT, and we do PET-CT, we do all together, and the patient is fine, should go to treatment. That's not happening in our department, so I recommend cooperation if you are wanting to be involved in this kind.
A couple of questions, please. For the work that you have done so far, it's like it's a clinical and research issue, right? Or it's only clinical work?
That's clinical. We practice it.
Oh, you are practicing?
Yes,
it
is
not
practice.
for the research issue.
No.
So the choice of choosing the patients was randomly. I mean, it depends when.
Well, you have to start with something.
Yeah.
You have to start with something, and we wanted to start to have some results.
Yeah, the point that because I want to ask you that you have, of course, you have seen like a cooperative patients and elderly or diseased patients. So for the one who are cooperative, when you are instructing them to threshold, they would do that. But for the, I mean, you have diseased patients. I mean, they're very diseased patients who cannot, follow your instructions. So you are following the gating respiratory process for them, right?
Yeah, that's well. Respiratory gating is not made for not to use polychloride. In our department, we felt that polychloride is not a good moment, because it brings a lot of difficulty with many patients. So we really feel that respiratory gating is better, not only for very diseased patients, but also for every patient.
Oh, so you applied for all?
Yeah. Also, good management. It was just we have to start with something. So you have a problem, motion artifacts. Then we say, we thought not work so well, there are a lot of problems. We have not cell, yes, but we have problem with compatibility. We have respiratory gating with the movement. Okay, fine, we did it, and then we keep it for that, because we felt that it was the better solution.
Fine. And this, sorry, but another question regarding the image that you showed us for the CT and uncorrected PET images, right? Of the lesion detectability.
Yes, because we have a PET CT scan before. So we always perform a PET CT scan without respiratory gating, so we can compare how respiratory gating affects the lesion, affect the part of which the lesion is found. And also, since we do on just one bed, we need a PET CT before to be sure that we are doing that, because it happens a lot of times that we are okay, there's a lesion there, and we find another lesion somewhere else. So we really need, really strongly suggest not to do just respiratory gating, but just to show, like they say, they do whole body, you just do that, not to do maybe total body, so not from the head to the feet, but just the whole body scan before it's really always needed.
I'd like to share our experience. The Kuwait Cancer Control Center, we do have the laser bridge, and the radiotherapists come up and they do the planning. So we do the whole body imaging on a flat table, and then they come in and they do the markers, and then we do the region that they want. If it was a lung cancer or a colorectal cancer, so we do have it in our department. So it's a combination of the nuclear medicine technologist and the radiotherapist. We're working together.
Yes, actually, you're more advanced than us, because we do it like a second, like a confirmation of the field. And what really often happens that with PET CT, we really find that sometimes the target is really misaligned. So they want to take something and maybe there is something else to be treated as more important. It just happens because a lot of patients didn't have a PET CT scan before. So we use both as a confirmation of the therapy and also as a confirmation of that. This is a problem with the radiotherapy department. That not only put faith, not only in PCT, but also in magnetic resonance and also in the diagnostic. They have a lot of, it's still, in my opinion, we can really improve in coordination in that. But it was not thought for that. We reached it after a while. There is a history in which we tried to do. The probably next step will be to work together. The solution is to start with the idea to apply. So you can do it with just one thing. In some new departments they are doing that, so we plan to do it all together. When you have two separate departments that try to work together, you have always a problem with coexistence of systems. And that's the main issue. So it's more difficult. It's not, it's achievable. But now we use it more as a confirmation of the plans. They use it as just a direct plan, like for example in Copenhagen. The fact that when you have to do it, you have also to do diagnostic CT with intravenous contrast. So really takes a lot of while. It can take 1 hour to do that. And so you have to think about it.
But if you have a big CT with diagnostic CT on site with a PEG dedicated, then you're going to have to do the CT as well as PEG for the management of the patient.
Yeah.
So it's easy up for the management of the patient.
Well, you can really have a full schedule for the patient. In one session, you can really have a good, confirmed diagnosis and planning for radiotherapy. You can do it. It's possible. With some effort, we can do also in our department, but we actually do not to do it. Well, with the written struggle, we try to. Actually, in the software is expected. So we have also software that helps us to regularize when you have really some data missing. Yeah, there is a possible to work after when you do the construction of the exam to minimize the effect with the software. So the problem is not is that usually we start when we find regular breathing. So the problem is when the patient stops breathing regularly during the exam. But we have a software that helps us to fill in the gaps with that. So to keep on and have like a simulation. You have all the breathing, you have 5 minutes with the current breathing, and the other you simulated the breathing was going on. So you have still a good exams.
Also, the gating does the software some averaging. If you have like something is going misty in one breath, it does the averaging where you have a nice regular
Yeah, it's, it's really important to have a long battle. About 10 minutes is expected to be sure to have enough counts that counts. Sorry for that. Sorry for the joke. You need enough counts that count so you can still, even if the patient you have to stop early, you have enough statistics to work on and do a correct exams.
Thank you very much, Dr.
Well, I want to thank you all for all the questions. It was really incredibly nice in these 2 days. This is my last presentation. I really want to thank again the organizer. It was really, really a great session. And thank you very much.
Thank you very much.